Hello everyone, I'm Dr. Rohan Khandelwal and I'll be talking about the FMGE high yield MCQs for your July exam. You can follow my Instagram and YouTube channel by the name of Left-Handed Surgeon. Now this is going to be divided into three parts. This is the first part which I'm posting right now, and it's a mixed bag of questions which I feel are extremely high yield for your FMGE exam, and you should just watch them at a higher speed. The questions which you just skip and move forward so that you can utilize them for that time for further revision. This is a constant question which is asked in the FMGE exam regarding the types of grafts. Now you know that a graft is a piece of tissue which does not have its own blood supply, and they've given an image and they've asked what type of graft is this. We know that this is a skin graft, right? Skin graft is a constant question asked in all FMGE exams. And skin grafting, we are taking it from the same person and putting it on the same person again. So this is an autograft, right? Autograft. These are the various types of grafts. Graft which is taken from the same person, this is an autograft. Graft which is taken from identical twins, this is also asked quite commonly. This is an isograft. Allograft is between same species. So that means you take the kidney from one person and transplant it in another person. And xenograft is graft from different species. So xenograft, you should know, xenograft have been used. Pig heart has been transplanted in a human. That is a xenograft. Now split thickness skin grafting comprises of, this question has been asked many times in the exam. So split thickness skin graft is epidermis plus some part of dermis. It is not only epidermis, it is epidermis plus some part of dermis. Please remember this. So split thickness is also known as a Thiersch graft, whereas full thickness is known as a Wolff's graft. Now the donor site, the most common donor site for split thickness skin graft is the thigh, whereas for full thickness skin graft it is the supraclavicular fossa, infraclavicular fossa, or the postauricular skin. Even the groin skin can be used. Now in split thickness skin grafts, we take epidermis plus part of dermis and we just need to do dressing. We don't need to suture that site. Whereas if we take a full thickness skin graft, we have to suture that site. And if I suture that site, I can never reuse it again for grafting. But a split thickness skin graft site, I can reuse for grafting as well. If we talk about the recipient site differences, split thickness skin graft is thinner, so it requires less nutrients. That is why there is better survival. Whereas full thickness skin graft, it is cosmetically better. There is better color matching. Skin appendages are maintained there, okay? And it is more resistant to trauma also because it is thicker. Now we know that graft survives by three methods: imbibition, inosculation, and neovascularization. Imbibition is in the first 2 days, then is inosculation in 2 to 4 days, and neovascularization is after 4 days. Humby's knife is used for which grafting? Correct, split thickness skin grafting. This has been asked many times. And if we raise the graft of the right thickness, you will see these punctate bleeding points. These punctate bleeding points will be seen. That means we've raised the graft of the right thickness. So you can see here, you can see the punctate bleeding points, and when the graft site heals up, you can reuse it for skin grafting again. This is meshing of the skin graft. Meshing of the skin graft is we make cuts in the split thickness skin graft, and this increases the surface area. Right, this increases the surface area, and it can increase the surface area by 1.5 times. Another advantage of making these cuts is that hematoma or fluid will not get collected beneath the graft. And if hematoma and fluid doesn't get collected, then survival is going to be better, because collection of hematoma beneath the graft is the leading cause of graft failure. Okay. So usually there's one question on how to prevent surgical site infection. What is the definition of SSI? SSI we know is any wound infection which occurs within 30 days of surgery, right? So any wound infection which occurs within 30 days of surgery is known as SSI, or surgical site infection. Now, what is the best method of hair removal in a patient planned for surgery? A lot of you think it is shaving, but Bailey latest Bailey clearly says that shaving increases the risk of infection. So it is clipping using hair clippers, which is the best method. The best method for prevention of SSI overall, what is it? It is hand washing, hand hygiene or hand washing. And one question which has been asked regarding hand hygiene in the last few exams are the 5 moments of hand hygiene. Now these 5 moments of hand hygiene, you should know that there is 2 before and 3 after. That is how we remember it. 2 before and 3 after, right? So before a procedure, before touching the patient. 2 before touching a patient, before doing a procedure. And 3 after means after exposure to body fluids, after touching a patient, or after touching the patient's surroundings. These are the 3 afters. So here we can either do hand wash, or we can use a sanitizer, Both are equally good. But there are 2 situations where a hand wash has to be done with soap and water, right? 2 situations where you have to do a hand wash with soap and water. That is, if the hands are soiled or you visited the toilet, then you have to wash your hands with soap and water. This is also an instrument, either this one or the circular stapler is frequently asked in the exam. This instrument is a linear stapler. This is a linear stapler which is used for Zenker's diverticulum. This was asked in your FMGE exam. It is also used for sleeve gastrectomy, which is a bariatric surgery. So this one is a linear stapler. And this one is a circular stapler. Circular stapler, this has also been asked, is used for stapler hemorrhoidopexy. It is used for stapler hemorrhoidopexy, which is the treatment of choice for hemorrhoids these days. And it is used for LAR, low anterior resection, for sigmoid and rectal cancers. Again, one question regarding sepsis is frequently asked, and either they ask about SIRS or they ask about Q-SOFA. Q-SOFA in the last 3-4 years has been asked multiple times in the exam. So which of the following is not a component of Q-SOFA score? So what exactly is Q-SOFA? Q-SOFA is Quick Sequential Organ Failure Assessment Score. That is Q-SOFA, right? You have to remember the parameters for the exam. Hypotension less than 100, altered mental status, and tachypnea more than 22. So 3 parameters: hypotension, altered mental status, and tachypnea more than 22. And if the score is 2 or more than 2, then it denotes a poor prognosis. So which is not a component? Lactate is not a component of the Q-SOFA score. SIRS is Systemic Inflammatory Response Syndrome. This is also asked quite frequently in the exam. This is mediated by IL-1, IL-6 and TNF-alpha. And what is SIRS? SIRS is body's response to inflammation. This is body's response to inflammation, that is SIRS. And what are the criterias? 2 or more of the following criterias. So temperature more than 38 or less than 36, WBC count of more than 4,000, less than 4,000 or more than 12,000, less than 4,000 or more than 12,000, or more than 10% band forms, respiratory rate of more than 20. So please remember this, in SIRS it is more than 20, whereas in Q-SOFA it was more than 22. Another question which they ask is that all of the following are features of Q-SOFA except, and there they give the respiratory rate as more than 20. That is the wrong option. In Q-SOFA it is more than 22 and heart rate more than 90. Okay, so if any 2 criteria are there, we call it SIRS. Sepsis is SIRS plus a known foci of infection. Means if the patient is having SIRS and supposing the patient has Fournier's gangrene, then Fournier's gangrene is the source, so it becomes sepsis then. This was asked in the exam. Injury to the leg, a soldier develops extreme pain and crepitus at the site. Crepitus means gas. Which of the following is the organism for gas gangrene? Clostridium perfringens. Okay. Which of the following features seen in all types of shock? So what is one constant feature of all types of shock? Shock, you know, is hypoxia at the cellular level. Okay, is hypoxia at the cellular level. So why is this hypoxia occurring? Because less oxygen is reaching into the tissue because of any cause. So one constant feature is decrease in tissue perfusion or decrease in oxygen going to the tissue. Okay. This is a very important hypovolemic shock. One table, invariably they ask this question. A patient is brought to the emergency room after a road traffic accident. Vital points towards shock and the urine output is decreased. Patient appears to be confused from the stages of shock. In which shock does urine output start reducing? So please remember this: BP, systolic BP, urine output and confused. Systolic BP reduces for the first time in class 3 shock, right? In class 3 shock. And I've told you class 1 is 0 to 15% blood loss. Everything remains normal here. Class 2 is 15 to 30%. Remember the scoring of a tennis game. Here there is going to be tachycardia, but systolic BP is normal. Class 3, systolic BP starts falling, urine output starts falling, patient is confused. And class 4, vitals not recorded. Not recordable. Vitals are not recordable. Patient is about to die, more than 40% blood loss. But the catch which I want you to understand here is that class 2 is mild, class 3 is moderate and class 4 is severe. So it doesn't start from class 1, please remember this. So it doesn't start from class 1, it starts from class 2. Class 2 is mild, class 3 is moderate, class 4 is severe. So this patient has moderate shock. And moderate is the decompensated phase. Moderate is the decompensated phase. Please remember this. This is extremely important from the point of view of the exam. I've just summarized that table for you. Okay. A male patient comes with a 3rd degree burn from neck till lower back. What will be the correct order in the management of this patient? Now we know that in burns patients also we follow A, B, C, D, E: airway, breathing, circulation, disability and exposure. So first thing is circulation. That means we have to resuscitate the patient, give fluids to this patient. Now because it is a 3rd degree burn, 3rd degree burns I've told you are reaching up till the subcutaneous tissue. So these burns we need to do debridement and split thickness skin grafting. Immediate debridement and split thickness skin grafting. So after resuscitation comes debridement, and after debridement comes split thickness skin grafting, which we've just discussed in the starting of the session. It is autograft. So resuscitation, debridement and autografting. This will be the correct sequence. Extremely beautifully framed question in the FMGE exam, and more clinical questions are now being asked. And I'm so happy that since the last 2 attempts, because of these clinical questions, the pass percentage is also increased. So you should be confident that you know the clinical subject and you will be answering these, you will be able to answer these clinical scenarios. Okay. A patient gets run over by a tractor and is brought to the emergency room after 2 days. He has extensive injury involving the lower limbs. Image is shown below. What would be the best line of treatment? So you can see here that all this muscle is now dead. After 2 days, the patient is coming. After 2 days means the tissue is infected. The muscle is dead. So what do we have to do? Debride. And after 2 days, when there is such a big defect, I cannot do primary closure. I cannot approximate the skin because it is infected. So what do? We do debridement and hyperbaric oxygen therapy. Hyperbaric oxygen therapy has been found to be useful in gas gangrene. It has been found to be useful in necrotizing fasciitis. So here the muscle is infected. There is necrotizing fasciitis which can develop. So debridement and hyperbaric oxygen would be useful. And once the infection heals, then you close it up. What severity does a GCS of 10 denote in a trauma patient? So we know that 13 to 15 is mild, 9 to 12 is moderate, and 8 or less than 8 is severe. So this falls under the moderate category. GCS again is a very important topic. Either they will ask you questions like this, or they will ask you GCS calculation. So you should know about GCS completely. You should also know that the most important score in GCS is the motor score. The single best score is the motor score. And always remember, we always consider the highest value. We always consider the highest value of GCS. Remember that, please. Okay. This question was repeated 2 times in your FMGE exam. Mother gets a 2-year-old pediatric child to the emergency room in an unconscious state. Child has been having diarrhea since the last 3 days. In ABCD evaluation, what does D stand for? I just told you. D doesn't stand for diarrhea, doesn't stand for dehydration, it stands for disability, right? So A is airway, B is breathing, C is circulation, D is disability, E is exposure. Again, a very important question which is invariably asked. They either ask cardiac tamponade or tension pneumothorax. Mostly in the FMG exam they ask tension pneumothorax, and they've started asking questions regarding chest tubes also now. Patient presents to the emergency room with road traffic accident. Patient is visibly breathless. Pulse rate is 100. There are dilated veins over the neck. Tympanic note on percussion on the left side. We can see that there are no lung markings which can be seen here. There is air here, so there is pneumothorax. That is why you have a hyperresonant note. And when there is pneumothorax, means air in the pleural space plus altered vitals, that becomes tension pneumothorax. And tension pneumothorax, what is the first thing which we do? What is the first thing in tension pneumothorax? So here they've said airway, they've not mentioned anything, so we assume airway is fine. Then comes breathing. So we have to insert a wide bore needle in the 5th intercostal space. We have to carry out a needle thoracocentesis. Right, needle thoracocentesis is inserting a wide bore needle, and in adults now it is 5th intercostal space, mid axillary line. Whereas in children it is the old one, 2nd intercostal space, mid clavicular line. Okay, adults I'm repeating, 5th intercostal space, mid axillary. Children, 2nd intercostal space, mid clavicular. And after this we have to put in a chest tube. We have to do a tube thoracocentesis. Another question which you need to remember is EFAST, extended fast. Extended fast, what is the full form of fast? This has also been asked in the exam. This is focused assessment sonogram. Focused assessment sonogram in trauma. And in this is nothing but an ultrasound done in the emergency room for a trauma patient. And you know we keep the probe at 4 places. What are the 4 places? Epigastrium, right hypochondrium, left hypochondrium, suprapubic region. And if we do EFAST, we keep it at 2 more places, thoracic cavity. So it becomes at 6 places then. EFAST is at 6 places. We are assessing the thoracic cavity also. And minimum amount of fluid this can detect is 100 cc. So EFAST can detect tension pneumothorax, and the signs which we are going to get are loss of seashore sign. Loss of seashore sign, we will get barcode or stratosphere M sign. Okay. Patient undergoes thoracic surgery and the left lung is collapsed. After chest physiotherapy, the left lung expands gradually. What is the finding on the chest x-ray? Again, I told you, here we can see on this side, we can see the lung markings are there. Right? Here we can see the lung markings. But in this area, the lung markings are absent. So what does the patient have? Patient has air. Left pneumothorax is there. Okay. You can see here that the left lung is collapsed and you can see absent lung markings. This is pneumothorax. In hemothorax, we will see an air fluid level and the CP angle will be blunted. CP angle will be blunted, or you cannot see the CP angle because there is fluid there and you will see an air fluid level, which is not a component of the American Association of Trauma grading for splenic trauma in with patient with abdominal trauma. Okay, so which is not a component there. Vascular injury is a component, laceration is a component, hematoma is a component, adjacent organ injury is not a component. So this is the AAST grading, right? Hematoma less than 10% is grade 1, laceration less than 1 centimeter is grade 1. Then grade 2 will be 1 to 3 centimeter laceration or 10 to 50% hematoma. Grade 3 is going to be more than 50% hematoma, more than 3 centimeter laceration. Grade 4 is going to be vascular injury. Grade 4 will be vascular injury and grade 5 will be a shattered spleen. Okay. Normally grade 1 and grade 2 injuries, patients are stable. And what is the investigation of choice in blunt abdominal trauma stable patient? Supposing they say that there is a patient who comes with splenic injury, patient is stable. What is the investigation of choice? It is CECT. Grade 4, grade 5, the patients are usually unstable, and in unstable patients, the investigation of choice is FAST. I've just discussed FAST with you. Okay. Now, this is another scenario which is frequently asked in the exam. A 32-year-old lady sustains a fall from a flight of stairs and is brought to the ER in an unconscious state. NCCT is done and the image is shown below. What is the diagnosis? Okay. So, typical scenario, they will either ask EDH or SDH or diffuse axonal injury. These three scenarios they definitely ask. Okay. So, you can see here it is a young patient, and patient is brought to the emergency in an unconscious state. NCCT, you can see a biconvex hemorrhage or a lens-shaped hemorrhage, and this is restricted by the cranial sutures, right? So this biconvex hemorrhage or lens-shaped hemorrhage is an extradural hemorrhage, and in extradural hemorrhages you can even get lucid interval. What is lucid interval? Lucid interval is the period of normal consciousness between two episodes of unconsciousness. That is lucid interval. Okay. So this is a contusion. Contusion, you will just get, this is intraparenchymal hemorrhage. This is the most common hemorrhage following head injury, intraparenchymal. But majority of these patients can be managed conservatively. Majority, there can be conservative management. This is EDH, I've told you, biconvex hemorrhage, and we need to do a craniotomy or we need to do a burr hole to drain it out. And the most common vessel implicated is the middle meningeal artery. And the location of the middle meningeal artery, to make this burr hole or drill, we do it in the region of the pterion. Now, pterion is a region in the temporal lobe, temporal region where various cranial sutures meet. And this is the site where mostly we do a burr hole or do a craniotomy to evacuate the hematoma. This is subdural hemorrhage. Subdural hemorrhage, you will have an elderly patient. There will be history of trivial trauma. Elderly patient, there will be a history of trivial trauma in these patients, and after a few weeks they will go into altered sensorium. So after a few weeks they go into altered sensorium. These are the key words you need to look out for. That is subdural, and on NCCT you get a concavo-convex or a crescenteric hemorrhage which is not restricted by the sutures. Concavo-convex or crescenteric hemorrhage which is not restricted by the sutures. Diffuse axonal injury. Diffuse axonal injury is the most severe injury. Worse prognosis is there, and the patient, the typical history which you'll get, patient is in coma, GCS is not improving. GCS is not improving, but NCCT is absolutely normal. Those are the key words which you should look out for in diffuse axonal injury. 50-year-old lady complains of worst headache of life. She has not experienced this headache in the past. So this worst headache of life is subarachnoid hemorrhage. Subarachnoid hemorrhage. This is worst headache of life, or thunderclap headache. Thunderclap headache. And this is usually due to berry aneurysms in the circle of Willis. Berry aneurysms in the circle of Willis is the cause for this subarachnoid hemorrhage. And if a patient is diagnosed with subarachnoid hemorrhage, we need to do clipping or coiling in that patient. Okay. So this was part 1 of the high yield MCQs. I told you there will be 2 more parts which I'll be posting, and I'll post one more video regarding the important images. So stay tuned on my YouTube channel. It is Left-Handed Surgeon. If you have any queries, put it in the comment section. I'll be happy to answer them. All the best for your exam.